Polypharmacy impact for the individual residents. This isn't rocket science. Most of us know these things. You got fall risk, increased risk for morbidity and mortality, increased risk of incontinence, constipation, cognitive declines, med-med interactions, decreased medication adherence. The more complex you make something, the more chance you have for error. Risk for hospitalization and increased morbidity and mortality over time. That's for individuals and populations. Anybody ever think in terms of this? And again, I'm not sure why some of the characters are coming through quite that way, but it's kind of a chicken or the egg thing sometime, right? Somebody has a side effect from a medication, we put them on another med to treat that specific side effect. So you got this one that cures insomnia, you get an upset stomach from it, you get one for the upset stomach, it causes itching. You treat the itching, causes depression. You know, we all see how this happens, and you get this prescribing cascade. You end up with people on way too many medications, and when you go to deprescribe, you start to have to ask the question, what was this there to treat to begin with, right? Anybody ever try to figure out where to start, right? It can be really hard to figure out where's the best place to start. Cost is another problem when you start to think about polypharmacy, right? So we talk about side effects, and one of those is the impact on the people who are paying for them, the economy. You know, we think about long-term care, a lot of people are on Medicaid, so this isn't as big of an issue, but when you're in the community and you've got people who are, you know, paying for their own medications, or they fall into that donut hole every year, this becomes a big problem. It becomes a problem for the patient, becomes a problem for all of you, because then you have to figure out what else to do. We're told to do the right thing for the patient, regardless of what the price tag is. But if the price tag isn't something that the patient can cope with, they're not going to have the benefit. Let's talk about staff impact a little bit regarding polypharmacy. So when you're working in an institutional setting, there is a burden to polypharmacy, and you think about the individual patient with 20 or 30 medications. Think about you have a whole building with people with mass polypharmacy. It takes time to pass all those meds, to stock the meds, to send them back, to manage that supply. And when meds change, then you end up with this buildup of meds in the med room. Someone's got to figure out how to send those back. So it takes a lot of time to manage. So it contributes to administration work. It contributes to staff making errors. It contributes to staff not really having time to have bedside care for the residents because they're putting blinders on all day long and just passing pills. Anybody ever see that? Yeah, we see that all the time, and especially in the long-term care setting. You see more transfers, and there's work for the staff that go into those transfers and then bringing people back and readmitting them to a community. You see more burnout and decreased job satisfaction. I'll tell you a story about a skilled nursing facility I was in. In my hometown, we launched into this facility. We were new to the facility. I come in, and the average med count per resident was 13 for routine meds, plus a variety of PRNs per resident. And the nurses were beside themselves trying to get their med passes done on time and actually get out of their shift on a reasonable time. Charting during their shift was almost a joke. It's like, we'll chart when our relief gets here. So over the course of 3 months, worked on a concerted polypharmacy effort with the interdisciplinary team, and we dropped that routine med list down from 13 to just under 8. We got rid of a lot of the PRN medications, and the impacts, the stories I started hearing, and we were able to, with the administrator, verify this. The nurses started coming to me and they said, you just saved us an hour per med cart per shift. 4 carts in this building, so 4 nurses per shift for day and evening shift. That's an entire FTE of nursing staff. 8 hours of nursing time per day eliminated by reducing polypharmacy. After that, we started seeing hospital admission rates go down. This home had historically been an extremely high utilizing home. from a hospital admission standpoint. Dropped like a rock. To boot, we looked at the complexity of the residents by evaluating their HCC diagnoses. And this building happened to be the most complex building we served in the state. And their hospital admission rates were lower than most by addressing polypharmacy. Additionally, the administrator came to me and said that his overtime for routine staff dropped to almost zero. Only thing I did was come in and address polypharmacy. So the impact on staff, the impact on populations and communities is huge. Let's talk about the population. And that's supposed to be decline in population ADL functioning. So I'm thinking that the format is somehow in the translation to the projector getting a little bit messed up, unfortunately. So decline in population ADL functioning when you have high-level polypharmacy, you see increased risk of dementia over time. Anybody ever hear that one? That was a little bit of a surprise to me when I actually did the research on this. Increased incidence of falls and fractures, not a surprise. The number one cause of hospital transfers in long-term care most of the time is either falls or dyspnea of some sort. We found in my organization that after hours, about 40% of hospital transfers were related to falls. We see increased hospital readmission rates too. So not just initial admissions, readmissions. In fact, about 19 to 29% of hospital admissions in this population are iatrogenic. We are making it happen to our patients. So if we are not paying attention, we are causing harm. So this is very important. This is one of the most powerful things you can do if you're treating a population of patients, especially older adults, is manage the polypharmacy. One of my rules when I was practicing was if I'm going to start a med, I'm going to see if I can get rid of something. I never started something unless I could see if I could get rid of something at the same time. You also see a decrease in overall life expectancy. If you're working in a facility type setting, what are the risks? There's a risk of citation. We talked about for staff, there's risk for errors. So that includes med errors. There's risk for poor outcomes for the residents, which then can result in citation. Increased adverse events to residents, reduced census because you have people going out to the hospital, you have people not living as long, so your census is lower. Reduced length of stay, higher overtime expenditure, we talked about that a little bit, and increased workload on the staff and increased turnover because of the workload. So let's talk a little bit about what polypharmacy reduction does in these various populations. So impact on individuals is largely the opposite of what we saw as the adverse events. Physical functioning improves. You see reduced risk of falls and cognitive impairment, reduced risk to go to the hospital, fewer med-med interactions, improved quality of life overall. So that's a big deal, right? Everybody have older adults that look exactly like this picture right here, right? No. Impact on the staff. So reduced time in medication administration. I think that's a no-brainer, right? But what is the impact of less time with medication administration? Well, we talked about the reduced hospital admission rate in this one facility that I served in. That's a result of the staff being able to have more hands-on time. Actually, the nurses going in and being nurses, assessing the patients, figuring out what's going on, identifying a change in condition. And guess what? You did them the favor of getting them off the med cart, so now they trust you and say, you know what? I want to talk to that guy when I find something that he probably wants to know about. Builds buy-in with the staff. So they actually let you know when there's a change in condition. In fact, they have time to let you know because they're not on the med cart all the time, right? So you find out about things early so you can intervene early when there's a change in condition.